Good morning, everyone. Thank you for coming. It's always nice to be back in Washington, D.C., where I went to undergrad and medical school and did my residency here. So it's nice to return to Washington. I live in Portland, Oregon. I've never been a West Coast person. I moved there 5 years ago, and I moved there to become Executive Vice President, Chief Medical Officer for Cambia Health Solutions. And I moved there and joined this company because of the cause. We don't have a mission, we have a cause. We're a cause-driven company. And our cause is about personalizing the healthcare consumer experience. And there's no better example of how we do that today than how we address palliative care and end-of-life care. And so what I want to share, knowing that this is constrained conversation around financing, I want to share our journey and how we have sequentially funded different aspects of what we do as a health solutions company, and that's the goal for today. I would be remiss if I didn't say we're preparing for the next 100 years of our company because we're celebrating our first 100 years this year. We were founded by doctors in Tacoma, Washington, Pierce County Medical, who at the time created an innovative way to solve a challenge for loggers who were going out into the forest and getting injured, and individually they could not afford it, and so they pooled their funds, and we were actually the first employer-based health plan in the country 100 years ago today. So proud to be part of this enterprise. So let me give you a high-level summary of our enterprise palliative care commitment. And I'll start in the left side of this document and talk about Cambia and our foundation, which began in 2007, but we made our first donation in 2009 and have sequentially made additional commitments. And so in our foundation, we're doing three major things and more in the context of palliative care. One, we funded the University of Washington's Center for Palliative Care and have made a pretty significant contribution to that. And in part, it addresses University of Washington's approach to hospital-based palliative care. And I don't have outcomes, and I know today is not the day to discuss outcomes, but what I hear anecdotally is that those investments are now bringing the returns and outcomes that we were hoping for. And it's also today named the Cambia Palliative Care Center at University of Washington. Similarly, we made a commitment to OHSU, the Academic Medical Center in Portland, and created an endowed chair for pediatric palliative care, and actually had somebody fill that position this summer, and we're looking forward to the results of that over the coming years. And last but not least, just talking about the bigger commitments we have made, we have created a program. Actually, Peggy McGuire here is leading that program, the Sojourn Scholar Program, which trains 10 clinicians each year for a 2-year period. We commit $180,000 over that 2 years, $90,000 each year, to essentially create the next generation of palliative care leaders. And I believe we're in our 4th year of that program. So 40 individuals now will have gone through or are in the process of going through that program. So from a foundation perspective, those are some examples of how we have leaned in financially and committed to addressing some of the gaps that exist in palliative care. ECHO, in the middle top, is our Health Ventures company. It's a joint venture we have with Blue Cross Blue Shield of North Carolina, and we invest in companies that are cause aligned with our cause. And one of those companies is GNS Healthcare, which is an artificial intelligence, machine learning type company. I'm not going to get into the detail and the lingo because I would get onto thin ice very quickly, but what they have done with their REFS program, reverse engineering forward simulation, is to create an algorithm to identify individuals likely to die in the next 12 months. And so we're using that in partnership with our palliative care case management program because we think we'll be able to find more people who will likely benefit from the services that we have in the marketplace. So that's another example of how we're leaning in. And then last but not least is some of the work that we have done in our health plan, and I'll talk about that in just a moment. And I couldn't leave this slide without saying that we are very focused on both the provider community and the network relationships that we have. We do have a broad value-based payment program, and in the context of that program, we have conversations about advanced care planning and are continuing to think about how best to formalize those in the construct of those payments so that we create the right incentives and don't have unintended consequences, and then community outreach as well. So from an enterprise perspective, high level, those are the kinds of investments that we've made, broad-based investments, and to address many of the gaps in palliative care. So let me go a little deeper in terms of health plan. We set out back in 2012, 2013 on a eyes wide open benchmarking exercise. We spoke to palliative care experts. We spoke to consumers. We spoke to providers. We researched the literature. We took all of that feedback. We looked at ourselves compared to other health plans. And we asked questions like, what should we be doing that we're not? What could we be doing that would really be helpful to the consumers that we're serving? And we collected all of that information and essentially did a gap analysis compared to our baseline, what we had been previously doing. And we have now begun a process of closing many of those gaps. And you'll see how we have done that in just a moment. It was a little bit of a wrenching exercise because it called out all the things that we should be doing for consumers that we weren't. But it was a very helpful exercise because if we were transparent and open enough to get that feedback and willing to put in place programs to address those gaps, we felt we were going to make progress in the marketplace. So, that's what we have done. And what that led to is a sweeping change in our benefits, the creation of a specialized case management program. We have 6 adult case managers dedicated to palliative care case management and 2 pediatric case managers who spend some of their time on palliative care. In the context of our program, we have created caregiver support, and that caregiver support occurs whether or not that caregiver is a member of Regents, so we're agnostic to who insures them or if they have insurance. We are engaged in the community. We have collected all the assets in our various communities that we are in terms of providing a portfolio to our case managers to help guide and enable navigation for these individuals who are in our programs. And as I mentioned before, we have also had dialogue, not just in the context of value-based payment arrangements, but in the context of our entire network when our providers are interfacing with individuals who have these needs and making them aware of what capabilities we have and what resources they can access. So this benchmarking exercise led to a sweeping change to how we approach and address palliative care, and we funded all of these capabilities because we wanted to do what is right for individuals, less so for the return on investment that these programs would return. We wanted to address the needs and gaps that existed in this space. So getting down to detail, what did we actually do? We started funding advanced care planning discussions between providers and their patients. It's not one discussion, it could be 5, it could be 10 discussions. We put no limit on it because things change. Things change in terms of an individual's illness. Things change in terms of their perception about what they want to happen or not. And so we didn't want to constrain what would happen during one discussion, so we fund any discussion that occurs. We provide reimbursement for home health medical, for pain and other symptoms that occur in these situations. We provide reimbursement for home health psychosocial. As I mentioned, we created a specialized case management program. And not only do we provide, in the context of that program, caregiver benefit, and as I said, whether or not the individual is insured, we're also acknowledging, recognizing that sometimes providers who have been caring for patients for a long time, who will have also grieved for their patients, and so we're providing support for them as well. I'm getting the hook, so I'm gonna quickly finish, but I would say that this covers all lines of business. We're agnostic, any age and any diagnosis. It comes in from our formalized algorithm that I mentioned before, or from anyone, from our call center, from our providers, from anyone caring for or interfacing with our members. So in the big picture, this is what it looks like. Just to wrap this up, we care from everyone starting at neonate to Medicare, to survivorship or remission. Sadly to say, we've had five individuals who are newborns that have been in our palliative care program, which we started about a year ago. We cover everything from serious illness to advancing illness to terminal illness, and all the supports that I mentioned earlier. So in summary, we've deployed resources and funding to support our personalized care program for individuals with serious and advancing illness. Our objective is to continually evaluate how best to serve these individuals, so we're constantly benchmarking and comparing. So our program is fluid, it's not static, it's dynamic. And while financial impact is always a consideration, we have to be thoughtful about that. Our funding determinations are driven by what is best for our members. We want to personalize the situation for them and do what's best for them. So I'll end there. I was only 35 seconds over the 12 and a half minutes.